Top Bed Talk. So we're going to move out of the operating theatre briefly and to the clinic around. So I'm delighted to welcome Dr. Fauzia Hasnie onto the stage, who is a consultant in anaesthesia and pain medicine at Guy's and St Thomas's, not too far from here. She has special interest in opioids, sickle cell, diabetes, neuropathic pain, and research interests in the same area. And we will be hearing her talk about an opioid reduction service. So welcome, Fauzia.
Well, you've heard about the opioid epidemic, and in the UK we've got an opioid crisis. Today you're going to hear me talk about how that's translated into our clinic, and also you'll hear some of our experience of how we manage patients in a chronic pain outpatient setting. First, I'm going to speak a little bit to the opioid problem in the UK, and then I'll talk about what we're doing at St Thomas's in the clinic, and I'll show you some of our outcome data. I'll speak about the considerations and strategies for opioid weaning, what works and what doesn't work in practice, and then I've highlighted some guidelines and resources for your interest, and that's also helped us develop the clinic. And then finally, I thought I would end with a patient video. So this is somebody who's been through the opioid clinic, who's managed to wean successfully, and he's talking about his experience. And I thought that would be interesting for you to see. So first to the opioid problem. Over the years, there have been a number of myths and misinformation. And in fact, the message in the 1990s, which was taken from our experience in palliative care, was that any pain can be treated with opioids, providing the dose is high enough, and that addiction is not a problem, because pain protects against addiction. And unfortunately, we've seen prescription opioids for chronic non-cancer pain increase. This is data that was published in June 2022, and it shows opioid prescribing in England. From 2004 to 2016, there was a sustained increase in prescription opioids for long-term pain. After that time, it plateaued, and if anything, it looks like there's a downward trend. The blue line is the cost, so you can see that as prescriptions increase, so does the cost, but then in 2016, actually the cost drops significantly. It's worth noting that in 2016, that's when the CDC, the Centers for Disease Control and Prevention, brought out their guidance, telling us that we should not be prescribing such high doses. And this is a snapshot of data of GP prescriptions in 2017, 2018, by class of medication and also by socioeconomic group. And you can see the most popular medications being prescribed, antidepressants and opioids. But what's noteworthy is that it is, unfortunately, the poorest and the most deprived segment of the population who are being prescribed opioids. When it comes to mortality figures, we can see that death rates from opioids are on the increase, and in fact, over half of all drug-related deaths in England and Wales have involved an opioid. So now to St Thomas's. We started the opioid clinic in June 2015. It's a multidisciplinary clinic, so we have a dedicated clinical psychologist, we have nurses, and myself. And we run the clinic monthly, so we see 4 patients a month, 45 minutes each, both new and follow-up patients. This is our early data, and I wanted to show you this because it really illustrates very well the scale of the problem, the sorts of patients we were seeing in our clinic at the height of the opioid crisis. So each bar represents an individual patient. There's 60 in this cohort. And it shows you the total oral morphine equivalent dose in 24 hours for each patient. The average is 675 milligrams, but it's a range from 140 milligrams to 3,840 milligrams. So that's nearly 4 grams in 24 hours. The average duration of use is 7.5 years. So these are patients who've been on these medications for anywhere from 1 year to 28 years. So I don't know if you can imagine, that's quite shocking to think that some of our patients have been on such high doses for such a long period of time. But we need to put it into perspective, and we talk about risk. So risk of harm with no added benefit we know escalates at 120 milligrams equivalent dose. Now that's risk of harm from respiratory depression, from accidental drug overdose and death. And in fact, we know that if you're on 100 milligrams morphine equivalent, you have a 7 times increased risk of death. So this puts everything into perspective. I think you can see the scale of the problem here. When we look at the demographics of this particular cohort of patients, it's a fairly even split in gender. The average age is nearly 50. We also looked at the source of the original opioid prescribing. So this is where the opioids were initiated. And in the majority of cases, 70% nearly, we found that they were started in hospital. Looking at the diagnosis, nearly 40% have a post-surgical diagnosis, a further third musculoskeletal. So it is hugely important what we do perioperatively in weaning patients even before discharge planning, and the advice we give to GPs to taper. These patients are complex, they're challenging, they have high levels of pain intensity, they have significant functional impairment, and notably, they are high risk for aberrant drug-related behaviour. So over 65% of our patients show behaviour or patterns of behaviour that would lead to the potential of misuse. There's also a lot of polypharmacy. So it's not unusual for our patients to be taking many different medications, but up to 9 different analgesics being used, and a quarter of our patients are on 3 different types of opioids. We've also done urine and blood testing. Because of that high risk of aberrant drug-related behaviour and the potential for misuse, we wanted to do urine screening to test for substances they may be taking. The most commonly picked up substances were cannabis, PCP, methamphetamines, and benzos. And what we found was that there was a correlation between testing positive for these substances and the risk of aberrant drug-related behaviour. But there wasn't a correlation between the risk of the aberrant behaviour and opioid dose. So it doesn't matter whether you're on low dose or high dose, what is more likely to be a factor is how long you've been on opioids for. We also looked at opioid-induced androgen deficiency. So in conversation with our endocrine colleagues, we talked about what tests would best show sex hormone dysfunction. We saw in our clinic, it wasn't unusual actually to see both men and women already on hormone replacement therapy in the clinic. And the literature tells us that 75 to 100% of patients have biochemical evidence of sex hormone dysfunction. We've demonstrated it in 90%. And it is hugely important because it has multi-system downstream effects. It can accelerate osteoporosis, increase fracture risk, cause glucose intolerance, and increase cardiac risk. And all of these things will be important as you manage patients perioperatively. It appears to correlate with the dose and the duration, but what we don't know is how fully reversible it is. We have seen when patients taper, and we've repeated blood tests, that the numbers do seem to correct, but that can lag behind several months. So it's very much a patient-centered approach in the opioid clinic. It's individualized care. It's a tailored program for the patient, using a shared decision-making model and taking on board all the biopsychosocial aspects. The aim of the clinic is to rationalize, optimize, and educate. So we want to rationalize this behavior that patients have of consuming medications without really knowing what they're taking, why they're taking it, what's benefiting them, and what's causing them harm. We want to optimize non-opioid medications and also non-pharmacological strategies. So what are the considerations in weaning? When do we taper? What are the preparations we make for dose reduction? And what strategies do we have for outpatient weaning? So firstly, when to taper? Well, basically, if the medication is not providing meaningful relief, if there's no improvement in function and or intolerable side effects, whatever the dose, then you need to taper and stop. If they're taking more than 120 milligrams equivalent dose and still no relief, taper. Likewise, if there's misuse or if there's evidence of diversion, then that's another indication to taper and stop. So the preparations we make when we first assess a patient in the clinic, we discuss with them the rationale for tapering opioids. We talk about the benefits and the risks, and we relate that to their specific medical history. We have a patient information leaflet that we give to them before they come to the clinic. We explore their motivation to wean. Some patients come to us and they have heard about the risks and they want to wean. For other patients, it's the first time they're hearing about this, so we do talk about that. We also think about the ongoing pain pathway. So it may be that if they can wean down their opioids, they can go forward for a pain intervention, a pain management program, or spinal cord stimulation. Patient engagement is key. It's really important that they take ownership of the process. It's very easy when you're on 20 different medications and you take them 3 or 4 times a day or more to lose control of that. So actually getting them engaged and giving them the control back really does help with the outcomes. At the start, we agree what the outcome is going to be with them. So we have a direction and a goal for them. We call that the exit strategy. These are patients that we do see in our clinic for months. What we want to do is bring them into clinic, help them to wean down, and send them forward in their pain pathway. We talk about the support that's offered for them in the clinic. Now, a lot of our patients are quite socially isolated. They don't have much support for this in the community. So there is a phone number they can contact, there is an email they can contact, and we do also offer one-to-one psychology support. We talk about the arrangements of a follow-up with our nurses, and we're very fortunate that we've grown in the clinic so that we have now 3 nurses who are involved, and we are able to offer follow-ups as early as 2 weeks. The usual follow-up is around 4 weeks or 4 to 6 weeks, and then we'll see them in clinic. So we talk about seeing them again within the whole multidisciplinary team. We anticipate and address right from the start the 2 things that our patients are most worried about, and that is withdrawal and rebound pain. And rebound pain can be a feature of withdrawal itself, so a lot of what we do is around expectation management. And then we work closely in collaboration with the patient, their carers if necessary, the GP, and any other medical teams that are involved in their care. We're very clear that we don't prescribe in the opioid clinic. Patients have a GP prescriber, they have a named prescriber, and we're very clear because otherwise it's possible that they may seek out prescriptions from us, from other specialists, from out-of-hour services. So if they know that their prescriptions are coming from one source, they're hearing the same message from everyone then. We also work in close collaboration with drug and alcohol services. So we're very fortunate at St Thomas's to have an inpatient drug and alcohol detox team. So there are several populations of patients that come to our clinic, and broadly speaking, they're sort of in these categories. There are those people who don't necessarily have pain and would like some advice on stopping, to those that have really poorly controlled pain and decline dose reduction. They don't want to go forward and stop their opioids. They don't want to engage. And those are the most challenging, most complex, because when things get difficult, actually what it comes down to is about containment and not escalating the dose. And sometimes that's the only strategy that you have. We make recommendations to the GP in that case, and we talk about safer prescribing and trying to make the prescribing and the dispensing as safe as possible. For some people, that means going to alternate day dispensing or daily dispensing of medications, which is a huge headache, but it's worth it to keep them safe. So what are the strategies that we use for weaning? Well, it's all about a personalised and shared decision-making approach with the patient engagement so that they feel in control and they're being listened to. In outpatients, we use a slow, flexible taper. That is more successful than using a fixed percentage dose decrease. And in fact, the typical sort of 10% reduction per week is no longer recommended for patients who are taking opioids for more than a year. So we prefer a more pragmatic approach. And that's usually a 10 milligram decrement or alternate decrements, usually every fortnight. Using small decreases at the start gains their confidence and trust in the process and reassures them that withdrawal is not a major issue. If they're struggling to taper, then we can extend that reduction period to 3 to 4 weeks, or we may pause even for a week or two, but no more than 4 weeks because you tend to lose motivation and incentive. And then, of course, as you get closer to 0, it's about more gradual decreases. So here are some additional considerations for outpatient weaning. Regarding the formulation, it's not unusual for patients to be on both immediate release and modified release, and actually both do need to be addressed, but we give the patient choice over that. We prefer addressing the modified release first because that's the formulation to which you develop tolerance and dependence more quickly. And anyway, when that decreases, tolerance lessens and they need less of the PRN doses. We always change liquid to tablet formulation. Our patients will do all sorts of things with liquid. It's very difficult to regulate. They may decant it into other bottles. They may take a few sips here and there randomly throughout the day. So it's very difficult to work out how much they're taking. Oromorph contains 10% alcohol. So it's not unusual we hear our patients say, Oromorph helps me, but Sevrodol does not. Well, it may be the case that actually the Oromorph is unmasking an underlying alcohol dependence that the patient may not be aware of. When it comes to weaning, we prefer scheduling doses rather than taking them throughout the course of the day. Now, the patients with chronic pain can have flare-ups throughout the day, and what may seem rational to them, taking a little bit every so often throughout the day, sets up a cycle of toxicity and withdrawal. And what we need for weaning is stability. So we prefer to schedule doses and then work at increasing the time between the doses to address the frequency. I've talked about the rate of the wean. It's a slow 2 to 4 week flexible taper rather than the fixed 10% dose decrease, and we like to agree the initial goal and outcome. Rotation is a very useful strategy, but we prefer to keep this just to the side. So we prefer to work with them on their existing opioid, but if they're not able to taper on that, or they've sort of hit a brick wall and they can't taper any further, or there's a lot of polypharmacy, then it's very good strategy actually to consolidate those medications and rotate to something else. And of course, as you rotate, you can reduce the dose. In our experience, about 25% works very well. You can go up to 30 or 50%, but that is more likely to cause problems with withdrawal. We've talked about the named GP prescriber and sharing the weaning plan. With regard to withdrawal, a lot of what we do is education at very regular intervals throughout their journey with us. We prefer that they taper more slowly, then go back up on the dose. We don't want to increase immediate release as they're reducing modified release. You don't want one to go up as the other one comes down because there's no point to that. But we also make use of alpha-2 agonists. In our hospital, it's actually only on the formulary for the inpatient detox team, but we prescribe clonidine in outpatients for a short period of a few days or up to a week, and that's usually 50 mics TDS. Patients worry about rebound pain, so we think about non-opioid strategies, other adjuvants. Gabapentinoids are opioid sparing, possibly, but caution with polypharmacy, and I would also say with risk multipliers. So the triad that comes up at post-mortem is gabapentinoids, opioids, and benzodiazepines. And then it's a point to note that anxiety also exacerbates withdrawal symptoms, so it's good to have psychology to support that. So looking at the outcomes for our patients, we've been able to demonstrate an 80% reduction in their opioid load. And with that, we see an improvement in pain scores of 30%, a 30 to 40% improvement in function, a whopping 75% increase in depression scores, and also in risk of aberrant drug-related behaviour. And that's really interesting because at the start I said there wasn't a correlation between risk of aberrant behaviour and the dose that you're on. But what we see as they wean down is that type of behaviour and those patterns of behaviour actually change, so the risk hugely decreases. Now, the average time to wean is about 12 months in our clinic, but it can take a lot longer than that. So these are some of the resources and guidelines that we found really helpful in developing the clinic. You'll be familiar with Opioids Aware, that was launched by the Faculty of Pain Medicine in collaboration with a number of other Royal Colleges and societies. I draw your attention to the NICE guidelines from 2022 on safe prescribing and deprescribing. It's not specific for opioids, but it talks about medicines that are associated with dependence or withdrawal symptoms. And then the updated CDC guidelines that replace the 2016 guidance. Now you've heard the practicalities of what we do in the opioid clinic. I've got a short video to show you, which is a patient who actually had a neuropathic leg ulcer. He'd been on opioids for about 3 years, about 480 milligrams. It took him about 7 months to reduce, but he managed to reduce to 60 milligrams, and he's just talking about his experience.
What was life like when you were on those very high doses of opioids? How was your quality of life affected?
I was very sleepy. I wasn't interested in anything. I did what I had to do and nothing more. As I said before, I had suicidal ideation and thought, oh well, what the hell, let's do it.
How did you find doing the actual reduction?
I felt I had a team at my disposal. There was Dr. Hasnie, and there was the nurse, yourself, and there was the psychologist who I saw regularly, who called me regularly as well to see how I was coping. Also spoke to a psychologist, and I know there was some linking between me and the doctor. I felt well supported and encouraged.
Good. And if you can summarize, what improvements have you noticed in your physical well-being, your psychological well-being?
Physically, I feel much more alive. Psychologically, I feel more interested in things I had lost interest. Emotionally, I lost my suicidal ideation.
I'm really sorry about the sound quality in that, but in this case you've heard his account of engagement in the process and actually his own recognition of the positive outcomes as a result. So just to summarise then, we need to recognise that high-dose medicine use is a sensitive marker of complexity, that reducing opioids is difficult, and for some patients the goal is not to completely stop, but to bring them down to a much safer level. Patient engagement is key, and please remember that when it's done badly, it can cause catastrophic problems and consequences. You can see overdose from non-prescribed drugs, mental health crisis, and suicide. And we need to encourage other elements of pain management. There are a few references here for you to look at, and then just finally to say thank you to our team of nurses and psychologists.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EPPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.